Start off by saying thank you for the opportunity to present this paper where we were investigating the effects of serial ketamine infusion on corticolimbic functional connectivity in major depression. So I will just start off with basically overviewing the paper. So starting with a brief introduction to MDD and ketamine, go through the study design, the acquisition protocol, and pre-processing pipeline, and go through the results, and then give you a summary of the results and what they could possibly be interpreted as. So it's well established now that depression is a leading cause of disability worldwide, with symptoms spanning over multiple domains. And treatment options until more recently were limited to monoaminergic agents, which may take weeks to show symptom reduction. They have a high relapse rate, and roughly 30% of individuals do not show response to 2 or more pharmacotherapies. So there's really an urgent need for improved, faster acting interventions, especially early on in diagnosis for these depressed individuals. So this is where ketamine comes in, which has been shown to be a very rapidly acting, robust treatment that can alleviate symptoms within days for 60 to 70% of patients experience treatment-resistant depression. And has been shown that a single infusion of ketamine can have lasting effects from a week to, in some individuals, up to 4 weeks. And other studies have also shown that multiple infusions within a short period of time can actually prolong that response and reduce that relapse rate to a little bit further down the road. So in terms of the molecular action of ketamine, it remains unclear still, but there are some working hypotheses of how it affects the NMDA receptor and then how the downstream effects may be leading to an antidepressant response. So I won't go into detail here. Mainly the focus of this paper was looking at major depression as a brain network disorder. Many studies have shown that these resting state networks are greatly affected in depression, and they're very involved in mediating mood, emotion, and cognition. So these are just symptoms that we see within the depressed population. So just to give you a quick overview of these networks that we were interested in looking at here, the first one is the default mode network, which includes the anterior and posterior cingulate cortex, the precuneus, the angular gyrus, and the medial prefrontal cortex. It's involved in attention, cognitive control, and rumination, and has been shown to be hyper connected within MDD when compared to healthy controls. The second network is the central executive network, which includes the dorsolateral prefrontal cortices and also the lateral parietal cortices here. It's involved in goal-directed functions, so decision-making, executive control, attention to tasks, and it has been shown to be decreased in connectivity, so hypoconnectivity in MDD. And the last resting state network that we're interested in here is the salience network, which includes the insula, the dorsal, ACC, and then also the frontopolar regions. And this one is really involved in detecting salient stimuli in our surroundings. It's involved in communicating and also self-awareness. And this network is hyper-connected or shows hyperconnectivity in MDD. The limbic regions that we were interested in looking at in association to these resting state networks are the amygdala and the hippocampus. These 2 regions are also very heavily involved in depression. They have been shown to have disrupted connectivity within MDD patients, so specifically the amygdala, which is involved in autonomic response to emotion and emotional memory, has shown to have disrupted connectivity with the dorsal cingulate, increased activation when doing a face task, And also anatomical changes were also found with decreased white matter connectivity to resting state networks. And the hippocampus, also involved in motivation and emotion regulation and susceptibility to stress, has been shown to be decreased in white matter volume and also has disrupted connectivity to frontal regions. So we became very interested in looking at the connectivity of these limbic regions to our cortex dominant resting state networks to really look at that top-down modulation of these emotion regulation symptoms in MDD and how those can be changed with ketamine. So that's why we decided to look at these network relationships. So in order to do that, we recruited individuals for our study, healthy controls, and patients with MDD. These patients were individuals who were treatment resistant, were referred to us by psychiatrists, and all of the MDD patients that enrolled in our study did receive ketamine infusions. So at time point 1, which is our baseline time point, we had 50 healthy controls and 44 MDD patients. And they were all evaluated using clinical scales and were all participated in an MRI. The group that received ketamine received the same evaluation at time point 2 after 24 hours post-infusion. And then roughly 1.5 weeks after that, and also 3 infusions of ketamine, we had another follow-up. And that follow-up happened 24 to 72 hours after the 4th and final infusion of ketamine. So at this point, we had 39 individuals who completed the infusions, and they completed the MRI and the clinical battery as well. And 17 of the 50 healthy controls returned for follow-up visit. And the reason that we had them do the MRI and the clinical scales was to make sure that the effects that we were seeing in our MDD patients were actually due to ketamine and not just an effect of time. So to go over our resting state fMRI and analysis protocol, to give you a quick summary of that, we first acquired the data on a Siemens 3T Prisma MRI system. We used the human connectome protocol sequences for the T1, T2, and the resting state fMRI. We then proceeded to pre-process this data using the Human Connectome Project pre-processing pipeline, and then we denoised and cleaned the resting state data using multi-session fix. We followed up by performing a group ICA with 50 components and dual regression on our clean data, specifically trying to identify our 3 resting state networks of interest. Then we extracted seed time courses for the amygdala and the hippocampus seeds. And then last, we did network modeling where we took the time courses for our limbic regions and our resting state networks, and we calculated that correlation between them. And that correlation is what we proceeded to do group level analyses on. So we looked at the longitudinal effect of ketamine. If there was a effect of ketamine, we looked at cross-sectional differences between healthy controls and MDD, and then we performed clinical correlations. Really quick demographic and clinical characteristics. There are no gender, age, or education differences between the ketamine and the healthy controls. We saw a 59% response rate in our MDD patients to ketamine. The response was measured after the 4th ketamine infusion, so post full treatment. The scales that we looked at for our clinical correlations were the rumination, the BIS, the SHAPS, and the DAS scales. The HDRS, or the Hamilton Depression Rating Scale, was our measure of response, and we didn't use that for the clinical correlations. So going right into the results here, we first looked at the connectivity of the amygdala to our resting state networks. So you see here that there are actually four. This is because when we did the component or group ICA, the central executive network was actually split into right and left. So we did it for each side. So connectivity of the amygdala to the default mode network showed no change with ketamine. Resting state connectivity between the amygdala and the right central executive network showed that there was a time by hemisphere effect, and therefore we looked at the right and the left amygdala separately. So here we saw that the functional connectivity between the right amygdala and the right central executive network actually increased after serial infusion of ketamine. And this increase was going in the direction of the healthy control. So there seems to be a normalizing effect. Cross-sectional analysis also showed that there was a significant difference between healthy controls here and baseline MDD. Looking at the connectivity between the amygdala and the left central executive network, we did see that there was a significant effect of time or change with ketamine. So there was this initial drop in functional connectivity after a single infusion of ketamine, and then a subsequent increase after serial infusion of ketamine. And there is no significant difference in that cross-sectional analysis over here. The connectivity to the salience network also showed a time by hemisphere effect. So we separated the amygdala into right and left and looked at the results separately for that. And we saw that the left amygdala correlated our functional connectivity to the salience network decreased over time with ketamine, our serial infusion of ketamine. And this was going in the opposite directions of what we're seeing in the healthy controls. But there is no significant difference between the healthy controls and MDD at baseline here. Then we further looked at the hippocampus and connectivity to our resting state networks, and we saw that there was no change in connectivity between the hippocampus and the default mode network. Also, no change with the right central executive network here. With the left central executive network, we did see a time by hemisphere effect. So again, we separated the right and left hippocampus and looked at the connectivity to the left central executive network. And we saw that the right hippocampus here had actually no connectivity at baseline with the left central executive network, but with after a single infusion of ketamine and after serial infusions, the connectivity went in an increasing of negative connectivity, so became anti-correlated. And there was no significant difference between the healthy controls and baseline MDD here. The connectivity from the hippocampus and salience network here also showed no change with ketamine, just like it did for the default mode and the resting state connectivity to the right central executive network. So we followed up these longitudinal analyses and cross-sectional analyses with the clinical correlates. So we first saw that the change in connectivity after single infusion of ketamine between the left amygdala here in the salience network was able to have a predictive nature when we looked at the BIS scale. So this is a scale that measures avoidance, potentially anxiety to an aversive situation. And in this direction, we're seeing that there's actually an improvement in that. So we're seeing an improvement in avoidance behavior was predicted by that functional connectivity change after a single infusion of ketamine. Here we were seeing the same effect, but this time we're looking at the change after serial ketamine infusions for that left amygdala connectivity to the salience network. So that followed through, that change is persistent and stayed so, and that did correlate with improvements in avoidance behavior as measured by the BIS. And lastly, for the clinical correlates here, we saw that, again, a potential predictive aspect here between the change in hippocampal connectivity to the right central executive network after single infusion of ketamine was able to predict the improvements in anhedonia that we saw at the end of treatment as measured by the SHAPS. So to just give you a summary of these results, again, we looked at limbic region connectivity to cortex dominant resting state networks. And what we saw was an increase in connectivity of the amygdala to both central executive networks and a decrease in connectivity to the salience network. And we saw an increase in connectivity between the hippocampus and the left central executive network. Looking at those cross-sectional analyses, the only one that was significant was for amygdala connectivity to the right central executive network, where we saw that the MDD group had hypoconnectivity. And as you can see here with the ketamine, they actually seem to have normalized towards the healthy controls. We followed up with the clinical correlations. So a decrease in functional connectivity after single infusion of ketamine and also after serial infusions of ketamine was able to predict improvements in inhibition and avoidance behavior, and decreases in functional connectivity between the hippocampus and the right central executive network after a single infusion of ketamine was also able to predict improvements in anhedonia. So what are the take-home messages here? We're looking at amygdala connectivity to central executive network. We saw a change there. We know that that relationship is involved in cognitive control of emotion, and that ketamine was involved in increasing this connectivity, which could be leading to an increased top-down control of emotion processing. And we know that that network is disturbed in MDD, so ketamine may be having an effect there, leading to that antidepressive response. Amygdala connectivity to the salience network is involved in emotion processing and perception of these emotions and self-awareness. And here we saw that that network was disrupted in individuals with MDD compared to prior literature, and that connectivity was becoming more normalized again in relation to previous literature. So we also saw here that post-treatment improvements in avoidance and inhibition were also correlated and potentially predicted by that change after a single infusion in ketamine. So there may be some plasticity of this network, and that plasticity after one infusion may be related to improvements in the avoidance or anxiety behavior that we see in MDD. The hippocampus connectivity to the central executive network, again, that's involved in cognitive control of emotion. And we were seeing at baseline that there was an absence of negative functional connectivity, so there was no connectivity, and that may suggest that there is a weak functional segregation between the cortical network and the limbic regions. Ketamine seemed to have restored some of that functional segregation, again suggesting that ketamine may be restoring that top-down regulation of these limbic structures to the cortex dominant resting state networks that we were looking at. and that this restoration of this top-down regulation may be related to symptom remission. And that is something we saw with the clinical correlations. We saw that there were improvements in anhedonia, which was correlated and potentially predicted by that acute single infusion of ketamine related decrease in functional connectivity. So just to quickly go over, after giving you that, the limitations and future implications. For limitations, we do need to validate these data in a larger sample, particularly for our cross-sectional analyses. This is not a randomized placebo-controlled trial, but we do know from many, many other studies that ketamine is an extremely effective and robust treatment option for depression. Our MDD sample was limited in their range of depressive symptoms, in the sense that these were very moderate to severe symptom individuals. They had been treatment resistant to 2 or more pharmacotherapies and had a very long history of depression. And then to move towards the future and what we want to look at and how we can apply this to the clinical community, really, from my standpoint, looking at the imaging aspect, looking at the triple network theory, to really understand how these 3 major networks interact with one another and how they produce symptoms in MDD and how ketamine can change those interactions. We want to look at long-term impacts of ketamine. That's extremely important in using ketamine as a primary first-line treatment for depression, and also to understand what happens when you stop the infusions and for how long can ketamine last, and how long ketamine can affect the brain networks. We're also very interested in looking at other modes of imaging for reasons of learning more about the effects of ketamine, but also how can we gather this data from other imaging modalities to potentially help understand who is the best candidate from the beginning to receive ketamine, and personalizing that treatment plan for them. So those are just some of the things that we are very interested in doing. And that is it for the talk. And I'm open to any questions.
Well, thank you very much indeed, Megha. There's a lot to chew over there. And it would be great to perhaps go over it in a little bit more detail, and perhaps a bit slowly. So what I really liked, thank you very much, was that fantastic exposition at the beginning of the of what these different networks do. So obviously this is your bread and butter. For some of it, it's less our sort of daily bread. Thank you very much indeed for that. Could I just ask a question about whether you can, and I would like to encourage everybody to ask questions, and to do that through the Q&A, please. We'll come to those questions in a moment, so please do enter those. How replicatable are these sorts of imaging studies?
I think they've been replicated. We have done the analyses in a few different ways to confirm some of these results are real. And like I talked about with the healthy controls, they were scanned at multiple time points. And when we did that, we were able to see a replication of these networks within those groups, and show that these networks weren't changing over time when there was no ketamine involved. These networks pop up every single time we do a group ICA. And with ketamine, there have been a few more studies, especially coming out of our lab, showing that these same regions are very much involved and changing within task fMRI, within perfusion that we looked at. So I think they're pretty replicatable.
Okay.
And I think there are some more recent studies also that have come out after this paper was published that have shown some similar connectivity changes.
Okay, great. And if you're having and this is a slightly bizarre question, but if you're having a dinner party conversation with your mother-in-law or something, and you wanted to try and explain to the lay person in the street, what was happening with depression in these networks and how ketamine actually affected them. Could you do that? I know that's really challenging.
I can definitely try to do that. So I think talking to anybody about my research that's outside of the fields, I would first explain that there are connections within the brain that are not anatomical. So we don't need to have a direct line of something measured by DTI or white matter tracks going from one region to another. There are time courses, and these areas of the brain are in sync. And in depression, what happens is that they become out of sync, and we lose that control from one area of the brain to the other area of the brain. And ketamine is able to almost like jumpstart that and help to rebuild that connectivity between these regions that are not necessarily anatomically connected immediately or directly. So that's what ketamine is coming in and doing, is restarting that aspect of it. And that could be helping those symptom improvements that we're seeing so quickly with these individuals.
Thank you very much. I'm sure she'd be pleased with that. Okay, thanks. So we've got some questions from the audience now. Tiago Gill asks the questions: what does a negative correlation mean in clinical practice?
So a negative correlation is an anti-correlation. So a correlation can be important in connectivity, that the two time courses are moving kind of together. So they're on top of each other, and we're seeing that like they're all moving in this direction. So that's saying that something is positively connected, they're working together. But it's also important to have a disassociation of these networks. We don't always want everything to be going at the same time. So actually, the central executive network and the default network are actually shown to be out of sync to the point that they're actually in sync. So when one is up, the other one is down. And that is an anti-correlation behavior. Instead of just going all over, they're actually kind of flowing with one another, but in the opposite direction. And that is a very important relationship for top-down control or for any sort of connectivity when we look at what should be up, what should be really going when you're resting versus what should be active when you're doing a task. So that's why we want to see that anti-correlation behavior in these networks. So they are correlated, just in the opposite direction.
We've got a couple of sort of questions about the sample. Can you and the sort of methods? Can you remember what the clinical dose for the ketamine was? Was it 0.5?
0.5 milligrams per kilogram.
Sorry?
0.5 milligrams.
Okay. And I noticed the MDD studies subjects were on antidepressants during the studies. What are your thoughts about the possibilities of these medications influencing the effects of ketamine on these networks, either positively or negatively?
They have to have been stable for over a 6-week period, and there are no changes. So we didn't expect any changes to be, we didn't expect any influences of those medications on their fMRI because they had been on these medications for a long period of time without any changes. So the only change that was happening was the addition of ketamine for each patient. And also because this was a study that we were looking at the same person at multiple time points, we were looking at them for 3 time points, you can expect that there's going to be, we're doing a within person analysis, correct? So rather than doing one sample against another sample, it is within person. So we're able to look at that and kind of control for the variable of the antidepressants that they're on. We did actually take individuals off of medications that could affect resting state networks. So like benzodiazepines, we had them come off of that 72 hours before the treatment. Again, we also worked with their psychiatrists in order to do that. And if somebody wasn't just not able to come off their medications, it was not a healthy option for them, then they were not enrolled in the study.
Thank you. And then there's a question here about structural versus functional imaging. It says cortical atrophy is paramount to major depressive disorder, which best evaluates this activity, functional or optical. And I think what Ramesh is getting at here is, did you control for structural changes in depression or?
No, we didn't control for the structural changes. I think that's a really important thing to control for when you are looking at cross-sectional analysis, so looking at healthy controls to MDD, but it becomes less of a factor when you're doing these within subject designs. Definitely in our case, we have, for this specific study, we used an atlas to look at the amygdala and the hippocampus. So that could be a structural issue there. But again, we looked at within patient, and we don't assume that we're going to have such large structural changes occurring within such a short period of time that we're scanning these individuals. And also in a prior analysis that I did, I actually used individual-based amygdala and hippocampus. So to control for that structural, I think it was Ramesh that was bringing this point up, to control for the structural differences between patients and with severity, and we saw similar results.
Okay. There's a question here which I think is hang on. Yeah, so were you surprised by the lack of effects on the default mode network connectivity to the amygdala and the hippocampus?
I was very surprised by that. That was definitely something that I expected to change. But again, it could be the sample size that we're looking at. It could also, there could be a number of things. The severity of the depression that we're looking at here could be an aspect of it. But I think a lot of it is that we do need to try to replicate this and the full sample of data. We do have a lot more data that's been collected since I published this paper. So to redo that, and we did have a recent analysis that showed that there were changes in the default mode network itself, not specifically to the amygdala, but there is data that I've analyzed looking at the resting state connectivity between these three major networks, and we are seeing a change in the default mode network with ketamine.
Okay. There's a question about a secondary analysis. So was there any relationship? You used a 0.5 milligrams per kilogram. Was there, if you just used the absolute ketamine dose, would that have, I mean, did you do that?
No, from what I have learned from our clinician, our psychiatrist that does the infusion, it is very important to do the infusions by weight because people can range, and the effect of ketamine can be very different based on the weight of the individual. So we stay pretty consistent on the go by the weight of the person. So no, we have never done any other dosing of ketamine or tried to keep a consistent dose of ketamine. I know there are some studies that have looked at 0.2 milligrams to kilogram. I've seen that recently there was a paper published on a 96-hour infusion. So there are some other studies doing different doses, but for our purposes, we kept to the 0.5 milligrams to 1 kilogram.
Does this picture of the effect on the networks parallel what you see with other antidepressants, or does it look very different?
No, it actually does look similar to some of the antidepressants. That's kind of what made me also want to look at these networks and the connectivity here. There have been papers that have looked at the default mode network connectivity and with that connectivity change with SSRIs. Yeah, it follows. It is definitely related to other studies and other treatments for depression. Even cognitive behavioral therapy has shown changes and similar changes within these networks.
And what about ECT? Is there anything
yes.
doing some of that?
Yes, we are doing ECT. Yes. So there, yes, similar changes with ECT. We do find these changes, or one of my colleagues actually published a paper looking at amygdala reactivity, 2 phases, and showed very similar results between the ECT individuals receiving ECT and the individuals receiving ketamine.
A very small one. Sorry, I just missed what you said.
Sorry, my colleague published a paper looking at the amygdala and amygdala's reactivity to a task fMRI during a task fMRI in patients that went through ECT and patients that went through ketamine, and they both showed a similar change with treatment.
Okay, so that was a task-based rather than a resting state.
That was a task-based, yes. We have in our preliminary analyses seen that that both ECT and ketamine have similar effects. Ketamine just seems to have a very quick effect. We usually don't scan someone after a single ECT session. We usually do that after like 2 weeks, so they've had about 3 to 4 ECT sessions. So comparing it to our later time point with ketamine.